Welcome to the System Leader Workshop, Achieving Speed, Spread, Scalability, and Sustainability in Health Systems. In this pre-work segment of the three-phase workshop, we'll give an orientation to our national research of what top margin improvers are doing compared to their low-performing brethren. Our partner, the American College of Healthcare Executives, of which we are faculty and have been faculty for over 20 years, sponsored research of 573 CEOs 2 years ago. 71% of those 573 CEOs indicated that as a result of the movement to value-based care and the impact across the entire industry of the Accountable Care Act, that the rate of change as a core competency within health systems and entities of health systems will become perhaps the most critical variable that defines the ability of health systems to thrive and achieve their missions in the years ahead. So in this three-phase workshop, as we enter the pre-work, the orientation to our research, it puts us in preparation for the senior leader session in this phase one, where we try to create some divergent thinking. We open our thoughts, look at the research, our own experiences, and begin to try to discern those variables that will assure a higher probability of success for our strategies and our transformational work. That will be followed by a phase two implementation workshop in which we come together in a convergent mindset to construct the characteristics of our deployment model. And then finally, after the first 100 days of our transformational work in phase three, we come back together to review our results and prepare for that sustainability phase by tweaking the accountability system and the accountability process. So as we look at the on-site workshop agenda and prepare ourselves for that, during that time, we will ask, did you review this YouTube? And then we'll do a refresher for 30 minutes about what were the key lessons or what did you glean from the observations that we have made in our research, as well as your own experiences, and spend the bulk of our time in a system leader self-diagnostic in which we're asking the question, what design characteristics of our transformation model will lead to speed, to spread, to scalability, and sustainability? First, let's ask ourselves principles of accountability and speed of implementation design in health systems. We see that on the left side, an organizational structure in which the system CEO charters several transformation teams for labor, non-labor, perioperative, etc. And those teams, once their playbooks have been completed, will go directly to the directors responsible for that transformation focus area, bypassing the entity CEO. That's a structure that we observe in about 75% of system transformation deployments. Compare that, however, to this structure on the right that we see in about 25% of transformation deployment, in which the system CEO charters in parallel several transformation teams and goes directly to the entity CEOs to hold them accountable for implementation, and they in turn go directly to the directors, holding them accountable. As you make this decision as to which you think will produce higher probability to results, why did you answer the way that you did? It's important to record that why question, because capitalizing on accountability as a concept requires understanding the factors that make better. And to more importantly make that point, let's look at a case study review of Nancy, our PACU nurse.
The challenges we're having in moving patients from PACU to critical care units, ICU and PCU. We have long delays in getting patients out, definitely throughput challenges. We have an excessive amount over time in the PACU caring for these patients that we're not able to disposition to other units. And that's creating, it's all serial, it's creating backups in surgery and causing some challenges there. It's like the dominoes are falling. We've done an extensive amount of analysis. I've done value stream mapping, some spaghetti diagrams, and I want to talk to you
value
about
stream map.
how
We had a company that came in. They laid it all out. We tried that 3 years ago, and it just didn't work. And here's some of the issues. First of all, the physicians aren't supportive of this. They like doing the rounding the way they do. They like keeping the patient there. And quite frankly, I think it's better for the patients. Secondly, if we try to get the patients up on the floor sooner, those nurses aren't trained for this. They're not critical care nurses. And I think our patients are going to receive better quality if we keep them in a PACU. That's why we keep them there 6 and 7 hours. And then there's the staff. I'll lose staff over this. If you come in and you make too many changes, you start talking about your data and the value stream mapping. So I just don't see how that's going to work here. We're a very unique hospital. We're not like other.
So as we dive into the variables that produce the kind of situation we see with Nancy and Alan in the PACU, leads us to a quest for understanding human factors engineering. Why is change so hard? So ask yourself, when you try to implement change or lead a change initiative, what are the common barriers to change that you encounter? So list your top 10 objections to change. And what do you believe the effect of these obstacles are on your rate of progress, your ability to make needed changes, the sustainability of those changes, and the ability to achieve, maintain, or improve margin requirements? Did you notice that none of your top 10 objections had anything to do with needing more analysis or the quality of the analysis or lack of thereof? Did you notice they were related more to human factors engineering as in Nancy's responses to Alan? That leads us to peel the onion a bit on our research of what can we in fact learn from top performers. Well, in our multi-year research, from which most of our college ACHE programs are constructed, we see that in the top quartile, the 21 organizations in our most recent work, that those organizations, the directors and managers, averaged 2.3 changes per manager and director per month. We look at the bottom quartile and we find that in those organizations, the directors and managers achieved only 0.1 changes per manager or director per month. Let's compare the two. Another way of looking at it is to say that during a period of time, in 1 month, top performing directors have achieved 23 total changes for every 1 change that a lower performing director makes. We've been able to, in our partnership with the American College, to isolate the 28 variables that we've affinitized into 5 buckets that drive sustainable transformational change. So if we look at a case in point here at Maricopa Health System in Phoenix, these 5 areas where we look at the red line being the baseline before they began their transformational work based upon the characteristics we're sharing here with you in this pre-work video. And then 100 days later, the second bar, where they've made a dramatic improvement, followed by improvement in the second 100 days, and then compare them to the green bar, the high performers. Notice that over time we see progression in all 5 of the key focus areas, particularly collaboration and understanding how to calculate financial impact from process changes. And just a couple of questions for illustration. Question number 25 by example. If someone has an idea on how to improve a work process, our culture makes it relatively easy to test the proposed change and experiment to see if it works. Notice that almost 80% of the directors in top performing organizations answer this question. Yes, it is relatively easy to test a proposed change in our organization, compared to a scant 22% in lower performers. Or question 31. When working on performance improvement projects, tangible financial gains are tracked, measured, validated, and the information is made readily available to all those involved in the project. Once again, notice that just south of 70% of the directors and top performers say, yes, we do track and validate financial return when we have improvement projects, whereas only 33% in the lower performing group. So when you pull all those 28 variables together, what does one observe about the characteristics of managers in top performing organizations? Well, first, top managers and top performers exude great confidence. Their lower performing brethren, a characteristic is they exude fear. They're afraid of change. They're risk averse. The organization's culture is one in which taking a risk or proposing a change is not, in fact, encouraged. Failure is not accepted. And in fact, some cases may even be punished. Directors and managers in top performing organizations handle ambiguity well. They don't need the analysis to go on for 6 months to find the perfect answer, because they realize that, first of all, that may be a pursuit that never occurs. And secondly, I know enough to at least pilot a proposed change. We find that they're persistent. They work through barriers and obstacles. We find that they don't wait on others to get started. We find that they seem to anticipate these objections, natural objections to change. And because of those factors, we see that they build confidence in those with whom they work. And for deeper dive into this information, should you be interested, we, with our partner, the American College, published this work, and we were delighted that it won the ACHE Article of the Year Award. If you're interested in more information or a little bit more than we'll discuss in this pre-work video, don't hesitate to contact us. So as we begin to better understand the characteristics of transformation change management systems, it is helpful and illustrative to compare the typical budget process in a health system or an entity of a health system with the way they design their transformational processes. So we see here on the left, how is it that the budget process is designed? Well, notice first, it's deliberately designed by senior leaders. It is not left to chance. Second, notice that participation isn't optional. Director can't say, I'm not really excited about that budget thing, and it's not my strong suit anyway. I think this year, I'm just going to skip the budget. Come back to me next year. I've just got too much going on right now to prepare a budget. Notice that there are hard deadlines in the budget process, and there's a very hard end date. Notice that ambiguity is tolerated. Nobody expects that the data are going to be perfect. We rely on historical information and do the best we can to project it into the future. Notice that it is connected to operational performance as well. And finally, notice that good budgets, as every budget system, has methods of detecting low performers and taking corrective action where necessary. Now let's compare that to the common transformational process that has quite frankly failed our industry to date. First and foremost, most are designed with a training approach or simply creating a playbook and handing it out to the field and stating to the senior leaders, directors, here's your playbook, go forth and implement it. Notice that change is truly optional. Now, they wouldn't articulate it that way, but look how long it takes to drive a change compared to the budget process. Protection of the status quo is quite common. Notice there's really a lack of a hard timeline. They're allowed to slip. We start off with a good, strong charter, but notice how many times that slips and how many times that delay is allowed to creep in. It's basically the mindset it's done when it's done. Notice that the transformational process, unlike the budget process, is looking for the perfect solution before we even begin to pilot a change. It is often disconnected from operations. And notice that it's driven not by individual manager accountability as in the budget process, but rather through committees and task forces. Teams hide accountability. One of the reasons the budget process works so well is we have a clear line of sight to an accountable individual. So as we begin to work together to design your transformation management system or to tweak it, first of all, in our work, we've noticed that strong performance in a transformation management sense is comprised of 3 steps. First, there's this rapid results phase. And in each of these phases, we're looking for 1% to 1.5% margin improvement equal to the operating budget. So let's say $5 million to $35 million, depending upon your size, of CFO validated bottom line margin improvement. That rapid results phase, where we really need to have all hands on deck. Wherever we can find assistance, we're gonna come up with it. In our work, that phase lasts anywhere from 100-day workout, one 100-day workout, 100 days, to 2 100-day workouts or 200 days. And that really depends upon the situation. If results are needed absolutely quickly, then the rapid results phase becomes really critical. Where time is our friend, then we can more quickly launch into the more important leader development phase. Again, we're looking for 1% to 1.5% of the operating budget. And that leader development phase will last 200 days to 300 days, so a year. In that, the 3 variables that in our work we have found successful is a leader development program we call LEAP that I'll review here in a few minutes. Secondly, and this is vital, that we provide 2 hours of coaching per senior leader, director, and manager every single month. We'll see why that's important a little bit later. And then finally, we recognize through discernment that what they need is training and change management. And then that leads us to the sustainability phase. And how long that lasts, I mean, it's ongoing, but the amount of return could be even patient experience or CMS or clinical co-management or other variables that don't necessarily have a margin improvement quantification, but are strategically vital nonetheless. In the sustainability phase, we provide organizations with a toolkit that we'll review in a minute. We coach coaches to better coach their directors so that our programs are then taken over by the health system. But this 2 hours per month continues to be a critical success factor as health systems move from being coached by us to moving into the sustainability phase. So when you take a look at what occurs in this transformation work, there are 4 variables that all of this seems to hang on. The first, and you can rate each of these if you wish in a self-diagnostic sense on a scale of 1 to 5, but the first variable is how strong is our idea database? How strong are our ideas? And they can come from a number of sources. Corporate systems are quite good more often in creating playbooks by focus area, labor, non-labor, clinical co-management, etc. Is there the presence of an idea database or ideas databases? Like our own database, as you'll see in a moment, has over 100,000 ideas that we've captured. But other idea databases include Healthcare Advisory Board, etc. And Lean is a strong tool for generating ideas. Not so strong in implementation, we found, but certainly good in developing ideas. If we marry that with developing our leaders, and as I had said in the previous slide, through a program we call LEAP, provision of 2 hours of coaching per month, and training and certification in change management. Leaders need enabling tools, results enabling tools, which in our tool set we call it CBA tools, but it's more important that in these 4 variables that system leaders recognize that enabling tools are a strong predictor of success. And then finally, the provision of an accountability structure for implementing the playbooks. We call our accountability structure, as you'll see momentarily, the 100-day workout. Those 4 variables lead to transformational change. So let's take a look at the leader development component. Excuse me. Well, what does LEAP mean? It stands for Leader Effectiveness and Accountability Program. Now, 2 words in that title, that program, are important: effectiveness and accountability. So it's not training. It's more applied training. It's more proving that you as a director have become a change agent. And the scale that we help organizations self-evaluate come in an x-axis and a y-axis, a matrix. And we're looking for everybody to be here at this A+ quadrant. Well, how do you get to the A+ quadrant? Well, the first variable is what we call the innovation scale. This is a hard number. This is a practical number. And so if we had those 2 changes per manager per month, as you saw in our research of what top performers average, that would mean even just to be in the column, the A column, the director has to implement at least 6 changes in the last 100 days. This empirical score of the percentage of completed plans. So once we have directors in these columns, we move to the y-axis. The y-axis is more qualitative in nature, and it's asking the question of our strong change, of managers who have driven change, proven they can drive change. How well can they lead others? And we ask this scale, this y-axis, for an evaluation. We help you discern on 3 components. The first component is how well does that change agent, how able is that change agent to coach others, his colleagues or her colleagues, in setting quick short-term goals for a process change. The second variable is asking how well can they coach other directors, their colleagues, to inspire others to desire the change as opposed to the more common what they're faced with is protecting the status quo. The third variable we ask about is how well can they coach their colleagues? Can they coach others to predict and remove the obstacles and the barriers to change? Those factors put together give us, in an organization of 60 managers, our first 6 to 8 leapers, we call them. Directors who have proven they can change empirically, and directors who we believe can coach others to do the same. The aim in the LEAP program is not to single out 10% of the directors, but rather that in every single 100-day cycle we have new LEAP directors. So by the third 100-day workout, we have 6 to 8 who have coached others, as you'll see in the next few slides, to drive change. And then we have another 6 to 8, and then in the third 100-day workout, we have another 6 to 8. So by the time we finish a year of LEAP, we have over 50% of the directors and managers in the organization who have gone through the leader development or leader effectiveness program and have demonstrated they can drive change and coach others to do so. How is it structured? Well, let's look at Maricopa in Phoenix as an example. That organization had enough directors to come up with 7 LEAP work groups. Here they are. Each of these work groups have 8 managers in a table. You'll see a picture of them in a moment. So what are their goals? What makes it effective, or what makes it accountable and effective? Those 2 keywords in LEAP. Well, this is the cumulative budget for the 8 directors in Dan Otis's LEAP Otis work group, $79 million. We set a hard 5% budget, non-negotiable, set by senior leaders. The CEO is holding as directors directly accountable in this work group for CFO validated $4 million. In this case, the 7 work groups, their goal adds up to almost $19 million, which is 5% of the operating budget. And here we see Manny Soto, Team Soto, this is Manny in the white shirt, asking every single month in a check-in around their 2.8 million goal, how are you doing in achieving your 5%? An important factor here is that $2.8 million is non-negotiable, and this group is accountable for it. So if any individual around the table says, my department is fixed, there's nothing I can do, Manny Soto, the leader, looks around the room, looks around the table and says, who can make up the gap for this shortfall? Because just because this department says they can't think of any ideas doesn't mean as a group we're off the hook. We still have to come up with $2.8 million. So who's going to make up that gap? LEAP works. As you can see here, just at the 90-day check-in. So we've still got 30 days to go. On their $18 million target, they've already implemented $32 million, and Kathy, the CFO, has validated that $32 million has now hit the bottom line. So that leads us then to what kind of skill development or training curriculum can we put in place with goals for every single 100 days? We want to see practical application of these skills. Well, there is a curriculum for senior leaders. There's a curriculum for directors and managers. And there's a curriculum for transformation leaders and PI folks or project managers who predominantly have coached the coach and learning to, as opposed to be the drivers of change, be the support for change. So which curriculum do you think drives transformational change? This curriculum, more of an analysis structure, value stream mapping, 5S, Gemba, that one, or this one, teaching them to overcome objections. How do you collaborate? How do you build collaborative work teams? How do you effectively manage teams? How do you inspire others? How do you rapid cycle test specific process changes? Why do you think? And you got to pick one or the other. So it's not that you're going to train in one of these others, but you see, understanding that why makes you a better self-diagnostician, and hence the system a better self-diagnostician of driving and constructing systems for transformational change. Let's look at the second of the 4 variables, results enabling tools, what we call cbatools.com. And this is what ours looks like. As you can see from the home page, we have a number of different tools. We have GPS, I'll review in a moment, which is a strategy deployment tool. We have Accelerator, which is for managers to enter their specific changes in quality staffing. We have over 100,000 ideas in the Bright Idea database that directors can search. A rapid cycle testing module for directors to enter 30 data points in a change that they may be proposing to assess whether or not the change had any untoward quality issues associated with it. And rapid budget variance response module. These modules cumulatively help to drive for strategy execution, accountability, making success or its absence visible, speed of results, idea sharing not only globally but internally in health systems, continuing to build an idea sharing database, proven pathways that work, and the availability of coaching resources. cbatools.com for health systems is customizable with your logo and what you call your strategies. Some organizations may call them pillars, others may call them, like Christus, call them initiatives. It's scalable today to the entire health system, and it creates standardized accountability. There is a standard work way to assess whether or not we're making progress on our key strategies. And it's a simple login. It looks just like that. And so there are a number of them. Accelerator, as I'd said a moment, real-time results tracking from the CEO level all the way down to the director and manager's specific change level, substituting Trovan IV for Trovan PO as an example of the level of granularity. GPS is, or Global Performance Strategies, is for the system CEO or the entity CEO tracking tasks that achieve patient experience improvement strategy or growth strategy or margin improvement strategy, whatever it may be, on a real-time basis. I think the important ingredient here in how we've constructed GPS is it includes both strategic results slippage detection and how that's resolved, and it contains a director and manager evaluation tool by pillar, strategy, initiative, or project. So you get two slices in the GPS application. In-quality staffing is a module that we will look at a little later, rapid budget variance response, etc. So of the tools, only one of them, rapid cycle testing, will I quickly illustrate here, and I think you can see why in a moment. Let's take an example here of a rapid cycle test conducted by Kathy, a physical therapy director at National Rehab Hospital in Washington, D.C. Kathy asked herself this question: with saving 1 hour each afternoon by coordinating therapy department appointments with other departments, I saved an hour. Were we able to increase our afternoon appointments by 2 new appointments every weekday? Obviously, this is a growth strategy. She's asking, was I able to do that or not? Or if we look at the environmental services director who is asking himself or this question in Yuma, Arizona, when the EVS request to clean time was improved, were we able to clean 1 more room for every EVS person in the afternoon, thereby reducing staffing in the afternoon? Were we able to do that without negatively impacting the quality as measured by EVS request to the time the room was cleaned? Or in triage. The triage nurse, ED director asks herself here at Floyd Medical Center in Rome, Georgia, when we improved time to ED bed, did our 20-minute to exam goal improve? And because of that improvement, as you can see, it dramatically improved here. As it improved, were we able to decrease the number of worked hours that triage is double covered? We cover triage with 2 and 3 nurses 24/7. As we improve throughput, were we able to capitalize on efficiencies and thereby have less worked hours? And then the final one that we use in kickoffs with directors as a case study. As nebulizer treatment time is decreased in the ICU, where might directors look for cost recovery? And how would a rapid cycle test be structured to assure that as we adjust costs or staffing, that the quality of our nebulizer treatment or ICU care was not negatively impacting? This skill of rapid cycle testing is absolutely vital to help solve the Nancy fear problem that we saw in the earlier video. Finally, let's take a look at the accountability structure, what we call the 100-day workout, and the characteristics that make it up here in this pre-work video. The 100-day workout model supposes that we are going to organize our work in trimester bites. And we're going to, with our assessment of our change capacity, that is, how many changes can our organization and its directors, cumulatively the directors, how much change can we handle here? As opposed to a lower performer thought of one project at a time, where you go into an organization, you may see they've got a team on Joint Commission, on physician office, clinical co-management, surgical wound infection, improving labor, missing meds, non-labor supply chain, throughput, ER, hand washing, lost charges, falls, compliance. You know the gambit. It looks haphazard when you take a step back and look at it this way. The organizers of each of these initiatives, whether they be transformational or not. Certainly don't see it that way because they're only one box. But when you look at it from the entity CEO level, it looks very haphazard. Directors are running hair on fire to go to the next meeting. The 100-day workout change model avoids that hair on fire. It simplifies the change process. Doesn't reduce the need for change. It simplifies the change process and its accountability. In this way, a lot of times we hear, oh, we don't have enough time for just one more initiative. Oh, we are so busy. Well, here's why you're busy. There are projects going on everywhere. The workout process is a time-saving vehicle as in addition to an accountability vehicle. So we set the third Wednesday of each month as the day that our initiatives, the key players, the key leaders come together and answer the question, how well are we doing in our 100-day progress to achieve the key strategies that we're trying to achieve in all of those areas? Being effective at that kind of system design requires, first and foremost, asking the question, what is our total change capacity? Often senior leaders and lower performers don't even recognize that directors do in fact have a change capacity. You noticed at 2 per month over a period of 4 months, our model suggests 8 changes over 4 months. 2 changes a month times 4 months is 8 changes. How are we at the system leader level and how are we at the entity CEO level? How are we going to allocate our change capacity? Now, you may argue your change capacity is already greater than 8, and maybe it is. You may argue it's 12. That just means you have more change capacity. The question remains, how well are we capitalizing on it? Are we leaving change capacity on the table? Are we wasting and squandering our change capacity? Top performers, not so much. Lower performers, they're wasting their change capacity by meeting after meeting after meeting in which no results are taking place. The goal is to have, for a group of 10 directors, 80 changes in 100 days. With 100% focus, improve on our strategic focus, we can leave no man behind. Every director has to contribute to the cause. This is a visual of how the 100-day workout is structured. This is a year of work in which in our transformational efforts we ask, in this 100-day period of time of 100% implementation of the playbook, you can see playbook creation precedes. In this 100 days, what are the barriers to impediment? What are the barriers and the impediments to speed of execution? We, at the end of that 100-day period, ask the question before we launch into the next 100 days, how well did we do in meeting our change goals? And how well did we do in managing our change goals? And are we ready for the next 100 days? And if we look at the structure with peeling the onion one level beneath, we notice that 3 times a year, we have a 3/4 of a day meeting in which the goals for that 100 days and the targets are reviewed. We provide new training, new tools, new focus area if appropriate. Directors are asked before they leave to come up with their, in pencil, but their next 8 changes, and they're told before they leave the room, their first 2 changes need to be planned out today. That's 25% of the effort. This is implementing the playbook work. Then we move into the rest of the 100 days in which we have a 30-day check-in, 45-day structured review where each VP meets in a team meeting with each of their direct reports to ask, how are you coming on your plan to implement the playbook, the part of it we're implementing in this 100 days, and so on and so forth. That is more than 75% of the effort, but the impact of this structure on culture is profound as we take a look at Nancy and Alan one more time.
Well, Well, that's great news, Jane. I'm glad to hear that the plan worked out well and the rapid psych test was successful. You know, I think we ought to showcase that at the next check-in. Okay. Bye-bye. Come in. Oh, hey, Nancy. How you doing?
Oh, Alan, I'm so glad I found you.
Hey, Nancy.
Oh my gosh. How are you?
Oh, great.
Okay, good, wonderful. I don't know if you remember me. I'm the director of the PACU here. I met with Betty, the chief nursing officer, just a little bit ago, and she reminded me that the focus of this workout is one more throughput, and the leadership team is really focused on this. So she asked me to stand up at our check-in, which is in 3 weeks, and present my plans on how I'm going to support the collaborative for the OR that's going to get one more case per day. And I got some ideas, but I could really
You need
use
help bringing it to fruition.
I really do.
Okay. And we can do that, and we have time. So we can take your ideas and develop a rapid cycle test to validate your thoughts on.
Okay, we've only got 3 weeks on that.
We have plenty of time.
Okay, so I don't want to look like a fool standing up in front of my peers. You're going to help me with this?
Okay,
So now, we talked about some of these ideas. I still have the same concerns that I did last time you and I met. I think I'm going to get a lot of pushback from the physicians and from my staff. So I still we're going to need some work with that. But
Let's walk through the improvement first, and we'll talk about barriers.
okay, just seem so confident in this. Okay, so one of the first ideas was having the anesthesiologist run through PACU a little bit earlier.
So, what changed, really, fundamentally, between those two scenarios? The one we saw earlier, a lot of resistance, protecting the status quo, and this one. Really, the only thing that changed was an accountability structure put in place. Not to embarrass Nancy, but rather to create a system in which Nancy is accountable and her accountability is visible, her success or lack thereof. Look how much easier it made the transformational expert or the project manager Alan's job. He wasn't having to convince Nancy. Why? Because the CEO and the senior leaders from the system CEO level through the entity CEO level and senior leaders, all the way to Nancy, the director, were holding her accountable for the change, not the project manager or the transformation leader. That person was the support. Alan was the support. That is fundamental. So what do you see in that typical, and I've done a quick 30,000-foot flyby of how the workout structure works. And during the workshop, we'll open this as a discussion point to make sure that at least the variables you've observed are known, and we'll bring your experiences to bear to ask, how do we design a more effective transformation management system? But notice what you saw. You saw accountability. You saw managers like Nancy expected to be called upon regarding their 2 changes per month or 8 changes over 100 days. Notice that the vice presidents and the CEOs are not bypassed. They are front and center. And you would see results to date rolled up to the vice president level, not just at the department level. That is, the CEO is not only holding the department directors accountable, but also each vice president. And accountability, which you didn't see because we didn't take time to review a check-in, but it's been made fun. Nancy presents and she's going to feel wonderful. Why is Nancy going to feel wonderful? Because she's getting a lot of kudos and applause from her colleagues and from the CNO and from the CEO. I want to bring Rob Thames, the former COO of St. Anthony's Hospital in St. Louis. Now Rob is the CEO of and uses this method at North Arizona Health System. But let's take a look at
the particular things around our workouts, our 100-day workouts, which instituted it was all about speed. But speed isn't about just go faster, try harder, manager. It specifically has to do, I think, with 2 things, technique and cadence. If you get technique and cadence right, you'll improve your pace, which is all about the speed. It isn't about improving at the same rate as everybody else. We got to improve faster. And the leaders need structure. And the structures that we utilized specifically had to do with the workout structure, chunks of time to focus on specific themes, accountability of monthly reportings, checkouts, pure accountability related to that, and then an expectation of improvement of a couple changes per manager per month.
So notice what the CEO there, Rob, or COO at the time, Rob Thames, had to say about the accountability system. Leaders need structure. I want to shift gears now to what we've observed as the high impact focus areas of the top performers. And I've seen some elements of your playbook, and most of these are covered. But the way we approach organizations is that in every 100 days, as I'd said earlier, we're looking for at least 1%, margin improvement equal to at least 1% of the operating budget every 100 days. We want that pace or that cadence, as Rob Thames articulated. And, our heavy hitters are these. These are the ones. And we've had over the years a number of different folk. We used to have ED on this list. And ED now is nested inside the organization throughput and capacity. And the way we approach capacity, by the way, or throughput, is that rather than go one department at a time, like peri-op or ED or discharge time of day, we bring all 60 directors together at the same time on that third Wednesday of the month you saw on the calendar earlier. And every person in that room is asked to do one more throughput in their particular department every 4-hour block or every day. So as an example, the operating rooms, just one of 60 people in the room are expected to have one more OR case per OR room per day. Transport, they're asked to have one more transport per transporter between 8 a.m. and noon. Housekeeping, is their goal is to have one more room cleaned per housekeeper between 8 a.m. and noon. I think you get the idea of an all hands on deck approach. Only one of these methods did I want to spend just a moment, and that's in quality staffing. I know this is more specific to the workforce or the labor transformation team than many of the other ones, but it is illustrative. It's a method we call in-quality staffing. As Sarah Sinclair, the former CNO of Cleveland Clinic, and you can YouTube Sarah Sinclair or YouTube Cleveland Clinic, or better yet, in-quality staffing, and you'll see her video to all the nurses in Cleveland Clinic in which she says in-quality staffing is the language of quality. It's the language of nursing in productivity improvement. The second thing in-quality staffing does is it's their data. It's not benchmarking from Albuquerque. It's their data historically. And the third variable that makes in-quality staffing work to drive radical change in 100 days is you're only asking the directors to close half the gap. We're not saying to the directors, you've got to become world-class immediately. You've got to only close half the gap. It eliminates the argument that the data are flawed. The caveat is, however, your first two changes have to start today. So let's take a look at the in-quality staffing analysis. Here you see a representative department, an emergency department at Yavapai Medical Center in Prescott, Arizona, in which on the left y-axis you see volume and staffing, yellow bar being volume, units of service, ED visits, and blue bar being, this is the number of staff. And these are data that the director himself or herself collect. This is not provided by some external benchmark. This is their data. That's why it's belief in the data. The operative axis, however, is the y-axis on the right side. The director and the ED in this case is asked, when you think about quality in your emergency room, how many patients can a nurse handle at any given time? Well, the answer to that, of course, if you follow the Emergency Nurse Association, is 4. But when they added through data collection, it's a trauma center. So when they added their trauma cases and so on and so forth, acuity-based, it averaged out that their budget, as well as the midpoint, is at about 3.75. Notice that would be the midpoint. But the high and low range that the director said the most we could care for with our acuity when we collected the data would be 3, but it should never drop below 2.5. So notice the data over a 281 data point statistically significant sampling of the times during the 24 hours. This is midnight, 2 at 1 a.m., 2 a.m., etc. Over a 24-hour period of time, over a third of the time, the department is not in quality. Therefore, a lot of opportunity. And notice also that if we had done this on a benchmarking average, this department would have probably been shown to have no opportunity. But yet, look at the opportunity they have when looked at through quality eyeglasses. In fact, this is, by the way, this is the app on the system. You're looking at graphs right out of the cbatools.com. So here's the way she's staffed in blue, and here's the way the department should be staffed in green. Now we get to a rapid cycle. Now we're to a point of rapid cycle testing. So we're not diffusing the argument just by sharing this director collecting her own data that they could have 2 RNs in the middle of the night, but rather rapid cycle test it just for one shift, and let's see if you have quality. You see if you have quality issues. For non-census based departments, we have them collect data that here at the University of Mississippi and the CT department, collecting data in a time and motion sense. Procedures we have found just do not work in non-census based departments. They work in census based departments, but when we get to the number of transports per transporter, the number of rooms cleaned per housekeeper, the number of codes coded per coder, what we find is that making improvements, that's procedure-based, is just not helpful. What's helpful is having the director collect time. How much waiting time are we waiting? Look, that 18% of this CT department's time is wasted waiting on transport, or 3.5% of the time waiting on lab or dosing, etc. Or if we look at another similar department, a physical therapy department, again at the University of Mississippi, where the evaluation time is not even 13% of the total hour that the therapists are spending. The rest of their time, look at this, almost half their time they're spending charting. It provides them an opportunity to do real process improvement work on the path of becoming more efficient, as opposed to an arbitrary benchmark that says you should be taking care of 4 patients per hour. That doesn't help the director. This helps the director. So let's compare that to a typical benchmarking or a procedure-based approach. In-quality staffing trumps benchmarking in buy-in, speed to action, results, and sustainability. Benchmarking, it's slow. It takes 8 to 10 weeks, often more. And the output of that is let us explain their variances. In in-quality staffing, their variances are irrelevant. It's fast. Using our 30 proven concepts for staffing change, our change concepts for staffing, they're expected to make their first 2 changes, or rapid cycle test their first 2 changes based on the data you saw earlier in the previous 4 or 5 slides, to improve the efficiency. Worked hours per unit of service, that's a resource comparison. It doesn't help the director. In-quality staffing is a process comparison. It's asking them to help self-analyze when and where do you have the right staff, the right place, at the right time. And so if you constructed a year-long labor or workforce management to drive 1% or more operating budget every 100 days in this model, is in addition to implementing the playbook, we would have them for the first 100 days. Let's do internal benchmark. Forget the external stuff. That is not helpful. However, let's take of your 26 pay periods, the 4th best one. You can't argue that you can't replicate the 4th best one. You might not be able to replicate the best productive pay period you had in the last 26, but by golly, it's hard to argue that 4th best pay period. 100 days, 8 changes, attempting to replicate the 4th best pay period in terms of productivity. Then we move into the analysis you saw in the graphs for the second 100 days in quality staffing, And then the final 100 days is what we call the rapid budget variance response. That is, how quickly can we predict we're going to have a budget variance? We aim for no later than the 15th day of the month. So if this, as it is, June 1, by June 15, every director in the organization should have a predictor that I will or I will not miss budget this month. That gives them 15 days to get back on track. There is no this 100-day workout. By the end of that, each director has learned response behaviors to assure they achieve budget every single month. There's much more in the appendix that we can review when we're on site. So that concludes our pre-work video, and hope that that gives you some baseline of ideas and concepts, so that when we move in to the System Leader Self-Diagnostic Workshop, we spend 60 minutes looking to achieve speed, spread, scalability, and sustainability. I look forward to seeing you at the workshop.